Okay, guys, today is our third practice for oral exam, vascular surgery. We're going to talk about lower extremity arterial disease, which is, I think, is very important because when you go to practice, 80% of your practice will be really lower extremities. So really need to concentrate on this session. And we can start. Oh, we can start here. Go this way. Okay, Sam. You want to start,
يلا
Sam?
يلا بسم الله. A 58-year-old woman presents to the clinic complaining of pain in her calves while walking. She can walk about 100 yards before having to stop for rest. After a few minutes of rest, she can walk another 100 yards before the pain recurs
Okay.
in her calves also. The pain is worse on her right compared to the left. She has no other significant past medical or surgical history and is an active smoker.
Okay.
Okay.
So first question, clinic. So you're in the clinic, she come like that. What are you going to do?
Okay, I will take more history and perform physical examination. History according يعني طبعا هو قال في السؤال إنه no medical problems, but I will ask her about diabetes, hypertension. She's only smoker. He mentioned she's smoker.
Okay.
We'll ask her about ulcers, wrist pain.
Okay, that's very good. Let's keep going. So
Okay.
you're getting all the information, okay?
And
So
physical exam. We'll examine the heart, lungs, abdomen for any surgeries, neurovascular exam, pulses. Yeah.
Great. Okay. So she's currently employed as a factory worker and feels that her symptoms are not limiting her ability to walk, but they make it difficult for her to stay active. She has bubble femoral pulses, biphasic pedal double signal without any evidence of pedal ulceration. What will you do next?
Okay. طبعا this is claudication.
Correct.
The next we'll do arterial duplex, we'll do ABI. Okay.
Why you want to do them?
Just baseline.
How are you planning to treat her, medically or conservatively?
For claudication, always we start with conservative control of risk factors, stop smoking, walking exercises.
Great. Yeah. So why ordering duplex ultrasound for EBI?
يعني just for baseline investigation and to compare it later on.
So this is correct. So you have always to order, even if you're not planning to do intervention, you still have to do a baseline, treatment, which is, diagnostic, which is a duplex as a baseline. So you can watch in the future getting better. The most important, not only is a duplex ultrasound, you have to do an EBI, okay?
ABI,
all right,
okay.
So, of course, the ABI is the most important to see how much blood flow. Because you may see like biphasic or monophasic, but you don't know how is this affecting her flow or not, So ABI is very important. And if you have a suspicion that patient has a vascular disease and ABI is normal, then you have to do an exercise EBI. Okay. All right, so at the baseline, the ABI is 0.7 on the right and 0.8 on the left. After exercise, so did exercise ABI, the right, you see why they drop? Because 0.7, 0.8 is not bad, but she has significant symptoms. So to reveal the symptoms, you have to put her on treadmill. The reason why they did that, So when you have suspicious that patient has vascular disease and bad claudications, but EBI come normal, then you have to put her on treadmill just to release her, or to see a significant drop in her EBI. So EBI on the right, it dropped from 0.7 to 0.5, and on the left from 0.8 to 0.65. How you interpret this finding and what your treatment plan?
I will say, this is peripheral vascular disease.
Correct.
And still, I will continue on conservative management, control of risk factors, stop smoking, and I will start her on aspirin and statin also.
Okay, this is good. But like, if you tell me like this is mean, I mean, what you said is good. That means has a vascular disease, you know. But if you tell
Yeah.
me what this means, that she has an iliac occlusion or stenosis or stenosis, then you get yourself to trouble, because there's nothing tell us that. ABI just tell
Yeah.
you what's going on the end. So
Yeah.
so don't be creative. Okay, so what you did is right. Just she has vascular disease. We don't know what's the level yet. You can tell from the pulses, of course, where's the level is, but
Yeah.
the
It's
question,
below.
this one, that she has a vascular disease in her tree.
Okay.
And now we're not going to say which level, because we're going to treat her conservatively. So, okay. So we
Okay.
did
He
that.
mentioned.
Sorry.
He mentioned that there are palpable femoral pulses. So
Right.
definitely it's something below knee or SFA.
This is not 100%. Sometimes you can have an iliac stenosis with
Yeah.
bubble pulses, correct?
Yeah.
And
Yes.
it can cause a drop in the BIs. I'm saying don't volunteer information you're not sure about it, because I can catch you up with this one. Like, if you tell me this one, I say, okay, can you have stenosis with normal, with femoral pulses? You see? So just answer exactly what the questions, okay? Don't volunteer information, okay? EBI is a
Okay.
vascular disease, this is, she's claudicant. I'll treat her conservatively. I'll do an active supervised exercise program. And then I would treat her with antiplatelet and statin and control her risk factors. The only question you may ask you, what you mean by supervised, exercise program. So maybe better not to mention, just say put on exercise program,
Yeah.
Because if you mention supervise, you must say, okay, what do you mean by supervise, Which is, we don't do it here, we just do exercise program. Supervise exercise program, that means she has to go to rehab, to go physical therapy, and she has to do them with the physical therapist. Somebody here watching her do the exercise.
Yes.
Which we don't do, we just do exercise here.
Okay.
All right. So she come back in a month and say that she is still having pain in her calf while walking, and is now starting to affect her work. Is anything else can we do?
Okay. Still claudication.
Okay.
Since there is no breast pain or ulceration, I will continue conservative management. Maybe we add another medication
Which is?
like Plital or silestazole.
Okay, what about Trental?
Well, some people they use Trental, but we don't use it. We don't.
Why we don't use it? We're not one of these some people.
Yeah, in our practice we don't use it, but I'm not sure.
Why? Is it cheaper? Is available? Is here? Is already available here? Why we don't use Trental?
It hasn't new vascular vascular new genesis effect, I think.
No, because we don't have any trial to confirm that it works. All the trial where they have a Trental versus placebo, the outcome was the same. So they did a trial already, Trental versus placebo, and they found it's no different. The reason why it doesn't work. Where Trental or silestazole, they did versus placebo, and they found significant improvement in the walking distance. The reason why we use a silestazole, okay?
Okay.
So we have a data, we have a science behind that. Whereas Trental, we don't have. So people there, we don't use it. People, they just use it. But really, we have a good trial where it's compared Trental with silestazole with the placebo, was no difference. But people, they're still using because it's the only drug available and will not harm, but will not benefit. All right, so she come back in the clinic 3 months. So you did that, you give everything, you give her Trental, you exercise, you control blood pressures, and then she comes 3 months with no improvement. Continue to smoke, and is now facing termination from her job due to her difficulty with walking. What is
okay. يعني usually احنا we have to
usually. Yeah, طلع Sam. In the exam, you cannot say usually. This is
okay.
a real.
Our,
Exam is a real life. You are in the clinic. You are a consultant now. We want to say what you want to do.
okay.
What do you want to tell her? You
I
can
will
do
consider
whatever you want to do, but just give me a good explanation why.
okay. I will consider it affecting her lifestyle. So I will do CT angiogram to assess the vascularity proximal and distal
That's correct.
for possible intervention.
That's correct. Usually, conservative measurement we give them about 2 months, and then we interfere. If it does not improve, if she's taking, then we have to do something. Yes, we always say that medication conservatively, but you have a limit. I mean, 2 months now, 3 months, they're affecting her work. She cannot go. She may be fired. Even if she continued to smoke, some people, she continued to smoke. You cannot do anything for that. I mean, this is her issue. You have to help this patient. You tell about the risk of continuous smoking, but then you have to help. Okay. So you're right. So get CT angiogram. Why you get CT angiogram? You already have arterial duplex. Why you need the CT angiogram?
Arterial duplex didn't mention about the iliacs. So
Okay.
we need to assess the iliacs, and for possible intervention, it's better to have CT angio.
All right.
Better.
So we need to have a CT angiogram because we want to know where the level of stenosis, how long, how big, does it need a surgery or interventions, Even some people, you can argue that if you have a femoral artery, if you're planning for endovascular and she has a good femoral artery, common femoral, you can go directly to angiogram because you can do diagnostic and treatment at the same time.
Yeah.
If you have femoral pulse, always better to get a CTA because you don't know where the level. Then you are dealing with the iliac, with the aorta, become more complicated. But if you have a femoral pulse, then you can argue both ways, If his GFR is high, and what about her creatinine, then I may go right away for angiogram. Okay?
Okay.
All right, let's continue. So your angiogram show moderate right external iliac artery stenosis, bilateral disease, common femoral artery, multifocal occlusive disease throughout the SFA with a short segment occlusion with reconstitution at the above knee popliteal artery, 3 vessel runoff, minimum disease of the left SFA with 3 vessel tibial runoff. How would you like to proceed? Her symptom mainly she has both legs, but the right more than the left when they start the study.
Right external iliac stenosis, moderate size.
Right.
Okay.
A bilateral disease, common
So,
artery.
yeah. We need to fix the inflow.
Okay.
So, since there is bilateral common femoral artery disease, we have to do endarterectomy, femoral endarterectomy, and at the same time bilateral femoral endarterectomy and angioplasty of the right external iliac artery, possible stent.
Okay.
I think for claudication, this is enough.
What, you don't have to go below?
For claudication, if we fix the inflow, probably the patient will improve.
Okay.
We'll keep the output.
So why you're the same? So why planning not to treat her right SFA? You just mentioned because when you claudication, you just need to treat the inflow. You don't need to treat the outflow. Same time. So all first concentrate on your inflow.
Okay.
Describe your procedures. This is our exam. This is always going to tell us about the surgery. So how going to do a surgery?
طيب.
Quick and go to the point.
Yeah, we can do it under general anesthesia or local with regional block. We put supine position, we prep both groins, then longitudinal incisions at the between superior iliac spine and pubic symphysis midpoint. Longitudinal incision bilaterally. We dissect and we identify the common femoral artery superficial femoral artery, and profunda. We control all of them.
Is the profunda
And
medial or lateral?
lateral is profunda is lateral usually.
Oh,
Yes.
okay.
And
What do
we
you landmark?
also
What do you landmark up?
the inguinal ligament.
Correct. Okay, continue.
Then before clamping, we give heparin therapeutic dose.
What therapeutic dose?
It's 80 to 100 units per kg,
Okay.
and we'll wait for ACT more than 250 if possible طبعا. But then
Okay.
longitudinal, then we clamp, and longitudinal arteriotomy extending from common femoral to SFA.
Okay.
And we remove the plaques, then we make sure no remnant flaps, and we test the inflow and backflow.
This. What if you have this proximal flap?
We try to extend our arteriotomy, but the proximal flap is not, sorry, if iliac.
Yeah, it's going extending to iliac.
Yeah, the inflow is not significant. The outflow is the most important. And anyway, we are going to do angiogram and angioplasty. After we check the back bleeding and the inflow from profunda SFA and common femoral, we put patch. Then either to go through the patch with sheath for angioplasty, or before closing, we can fix the sheath and do angiogram. We insert our wires, our sheath, then wire, then catheter, and we take one-shot angiogram to assess both iliacs, common iliac, distal aorta, common iliacs, internal and external iliacs, and according to the CT, we have to fix the right external iliac artery with balloon angioplasty, possible stenting. Then we put drains. Some people, they put drains, some they don't. Close the exploration area with running sutures, good bites, and skin. That's all.
All right. This is a very good answer. But the problem, you see, I'm liking somebody reading the book for me. It's not somebody doing a surgery. You see, this is different when you tell me like I can do so and so. This is not a surgeon. You're not. It doesn't give me the confidence. You know, the confidence surgeon, he will describe the surgery is just one step. I do this one. I open, do endarterectomy. I tag the distal flap. I put a patch. I put a burr string. I put a needle through it. You see, you don't give me two options. I can go through it or go from a side. This is not. This is, you read it. This is a book what he's saying. But what are you going to do? As I'm saying, in the exam, you have to tell me what you're doing. I don't care about the other options. So always the exam, try to be specific, confident when you talk. This is what I'll do. You know, I will go there. Either we can go either way, but choose one. Don't give me two. But Sam, you understand? Don't give me two options. You give me, okay, I put a burr string, I go through. Oh, you tell me before I finish my anastomosis, from the side, I put my sheath, I do an angiogram, I put my wire. You see, always I. Don't tell me we can. Don't use we. Always the exam use I. I will do so. I will do so. And don't use we. Any can. There's nothing can in the exam. I will do so and so. I put the sheath, I put my wire, I put my balloon, I do angiogram, do a commission angiogram. If I sign dissection, I'll stent it. If it's flow limiting, non-flow limiting, you know, then I will decide, I'll finish, I close the wound in layers, I put dressing, see, everything I, you know. So this is the only thing you have to pay attention to that. My question to you, why you have to do patch and then go through the patch? Why just go angioplasty, stenting, and then you put a patch?
To allow the flow. يعني if I didn't finish the patch, there will be no flow, so the angiogram will not be 100%. So it's better to allow the flow and for the ischemic time also. For the leg ischemia.
No, say that again. I didn't get the answers. First reason, why is that? Because of flow?
يعني to establish the flow, so the angiogram will be real angiogram, and to minimize the time for lower limb ischemia.
Okay. How long you see, now I ask a question I was not planning to ask you. How long the leg can tolerate ischemia?
يعني up to 4-6 hours.
Okay. So how long it take you to do iliac stenting?
Yeah. So we clamped for the endarterectomy. Yes, you are right.
So this is not the right answer. We got the first answer. You said for flow. Doesn't matter. Actually, flow is better when you clamp because the contrast will stay there. You can see better. You see? When the flow is open, the aorta is against you. So when you inject, you cannot see very well because unless you put catheter all the way in the aorta. But you inject from the iliac, you don't see very well because the aorta is not flow coming against you, you know? So contrast will go down. This is the reason why when we do an iliac, we want to see iliac, always we put a catheter in the aorta. So this is not the right answer. The right answer is that because if you do it and then you clamp, then you have a stasis flow in this external iliac.
Okay.
Or iliac, if the internal is occluded, then the stent may thrombose. This is the main reason why we do it after. Okay. Unless you feel the camel and the internal is open, then I'm fine. I may accept it. But if you're doing external, and then you put stent in the external balloon, and then you clamp the external to do your patch, in the meantime, you have no flow in the external, be static flow, then you make it thrombose or stent because the stent is thrombogenic. So you just put it there.
Okay, so we can
like to have a flow before we do the intervention.
Okay, so we can do the angioplasty of the external iliac before doing the patch?
It's better not.
Okay.
No. I prefer better, as you said, I prefer the way you did it, but I'm explaining why. The why we do it, because if you put any stent, you know, then because if you do angioplasty before and then you have to stent, then you're stuck now, you see? Well, if you get dissection, you see, you cannot take your wire out because, and then you put, you have to keep the wire there because if you take the wire, you cannot go back to the true lumen. So if you do a ballongioplasty first, you get dissection, you cannot stent because if you stent and clamp, you're going to thrombose your stent. Then you have to do a patch. Then you have to do a patch where the wire there is more complicated. You see my point?
Yes.
Clear. So it's better always finish it, put your patch, restore flow, cannulate the patch, and do your interventions.
Yes.
Because the worst thing to put a stent, and then you end with clamping the external, and you get really, especially if the internal is occluded, then you have a static flow, then you may thrombose your stent. Okay? This is the main argument. Okay.
Clear.
Would you add any medication after your intervention? How would you follow up this patient?
Yeah, we add aspirin, Plavix, post angioplasty. Okay. And we continue on statin. طبعا we give painkillers and we follow after 1 month, 3 months, 6 months, then with ultrasound, arterial Doppler, arterial duplex ultrasound, then annually, if no problems.
Good, excellent. She stopped well. She does well after the procedure. She discharged 2 days later. She comes back and most of the day with excessive fluid leaking from the right groin. What do you do?
Okay. So this is lymphocyl or lymphoria. Okay. We start with consult management, compression, dressing, ice start. Okay. And observation. Then if continued, we can I can use other modalities like injection of.
I will, not I can, I will.
I will start with injection of like tetracycline or.
You know the dose, how you do it?
No, I don't know.
Then don't mention. Then don't mention. As I'm saying, not to say it's better than say you don't know it. You see my Sam? If you don't know it, then don't forget. So you can do compression. If it doesn't work, you can send her for intervention radiology.
Yes.
Embolizations.
Yeah.
And
if
the last
didn't
one
work, then exploration and ligation or cauterization and
How
closure.
you can ligate them? How you can see them? Can you see them? The leak? How you can identify the leak?
By injection of methylene blue.
Correct.
Yeah.
Where?
At the digital spaces in
Correct.
the
When?
workspaces.
When?
During before opening, we inject the
No, it takes a
methylene
long
blue.
time. It takes about half an hour. So you have to do it
Yeah.
half an hour. So usually we do it in recovery. You know, before or holding area, before patient.
Holding.
Because it takes half an hour, 30-minute rate to get the contrast go up because lymphatic is very slow. It's not like arterial. So you have to do it, you see. So you have to do it this way. Or you can explore and do layers and like it. When you explore, yeah. All right. So the 1HR raw and partially separated. There is a saturated dressing with straw color fluid. CT scan showed fluid collections superficial to the artery and no gas. What we're going to do now. What did you forget before I go? What did you forget when you treatment?
Medical.
Yeah, when she came with the lymphocyte, what else you have to do? I just remember now.
بعد الانجيوبلاسي ولا مع الوند
With the first you see her, what do you do with the first you see the patient with the lymphocyte?
We give antibiotics. We give antibiotics. We give antibiotics. Yes.
Yes, because the high risk of graft infections.
Infection, yeah.
Infection, you know, have a patch here. Patch infection. So the first thing when you see lymphocyte, put antibiotics is the first thing. Then you start doing whatever you said. Okay. But now look at that. The HR raw, partially separated, saturated dressing with straw color fluid, like, you know, lymphatics, collection, no gas. So what do you do?
I will do exploration and closure in layers.
Correct.
And possible muscle flap.
Okay. I don't think you need a muscle flap because no infection here.
Yeah.
But I have no problem with that, you know. But may I ask you how you do a muscle flap, you know? So
okay, we take
this exam is a real life. I have to know that you told me you can do it. I'm sure, like, how you can do it. If you don't want to do it, then don't do it. Don't mention it.
Yeah.
If you plan to do it, then tell me how you do it, you know. So then I have to tell you ask you how to do it, you know. So yeah, okay, you can do that. But the most important, like now, is no place for conservative because the wound is already raw edge and partially separated. So she has to go back to the wall, really clean it up and close it in layers, you know. Sometimes I put a retention sutures, you know, big retention sutures.
Yes.
Yeah, muscle flap could be an option. Especially, I mean, muscle flap, if you see already the patch is exposed. If I go there, the patch is completely closed. I don't see the patch or the graft, then I'm fine just by closing in layers. But if I see the graft or patch, then yes, I have to do a muscle flap. Okay. What would you do if when you're expressed and start, here you are, you saw your patch, then you do muscle flap, okay?
Okay.
Oh, you finish. Okay, that's good. See, you pass your session. That's good.
Alhamdulillah. Barakatak.
Dr. Samer, from practical point of view, if we go retrograde from the same femoral, the sheath will basically cover almost half of the external iliac. How would we stent it? Pull out the sheath a little bit?
Yeah, you can pull it all the way. You are open. It's very easy because it's not different from percutaneous. Percutaneous, you're afraid also if you pull too much, you come out. But here, what I do, I put a hemostat at the entry of the sheath to the patch, so I know where it's going in. And the fluoroscopy, I can pull it as far as I can, you know, is the best way. And sometimes you can just take the sheath out and do it without a sheath because it's open, everything's under control, you know. So even you can, like, if the balloon is really very close to the junction external with a common femoral artery, at this area you have a stenosis, and your patch reaching all the way to the area of stenosis, then as you said, no place for the sheath. Then I put my balloon, pull out the sheath completely out. I may hold the common femoral in my hand to stop the bleeding, and do ballooning as close as to the suture line. Here you can do ballooning with a suture line because you are open. If the rupture, you can always fix it. If it's closed wound, fresh wound, you cannot do balloon angioplasty suture lines because you can rupture it and you can big hematoma. But as far as I'm open and I can see any damage, it's okay. I can be like more aggressive, you know. Any other questions? Okay. Rafa, do you want to take this one?
Yes,
بس
please.
دكتور عفوا معلش
تفضل
يعني بس سؤال للامتحان يعني ما في داعي اني اقول we can fix the SFA at the same time صح for claudication no need and since there is no wrist pain no ulcers
No need.
no need yes okay
No need. Unless if you have a problem with the inflow, you know. Like you say, like let's say the profunda is occluded and SFA is very diseased, then you need an outflow. You see my point? If the
Yes.
profunda is good, then I'm
Yeah.
fine. Just get flow to profunda. Let's say the profunda is occluded, and the only outflow you have an SFA and SFA is disease, then you have to fix inflow and outflow even for claudication because otherwise it will be clotted. You see, the way you have to argue. Is I'm saying the good thing about the exam is not like black and white, it's an argument, you know. But whatever you want to say, you have to find explanation why you're going to do this one, you know. But don't volunteer information, you know. I mean, if he didn't tell you, okay, I do this one. Don't tell him, oh, okay, but if the povidia is the profunda is occluded, I will do this one. If the space, no, don't get yourself to trouble. Just say the minimum, go to the point, I do a patch, I restore the flow. Even with the patch, you mentioned you get it to the SFA. As I'm saying, don't give too much information. I put a patch. If he asks you, then you tell him, okay, I'll take it directly to the SFA. If SFA is occluded, may directly to the profunda, you know. But try to be direct, minimum information to the point, you know. And don't try to too much talking doesn't impress. It doesn't mean that you know too much. People just like give information that mean you know. No, ask a question. Exactly the answer and stop. You don't have to keep talking. Okay, even if it's like answer 2 or 3 words. You know, explain. Go directly to the point and show confidence. This is what I do. I will do so and so. You know, and so you don't have to explain why you do it unless he asks you. You know, I'll do a word to buy FEM. Unless something you think you need explanation, or he may ask you why you want to do this way and tell him it's so and so. Otherwise, just go to the point. I'll do so and so. I'll do so. I'll do say so and so, and just keep going. Okay. Especially your time is limit.
Okay. Thank you.
All right. All right. Let's go, Rafat.
70 years old man presented to the clinic with the worsening pain in the left foot that we wake him up at the night and is relieved by dangling his foot off the bed. No history of the coronary artery disease, but he is type 2 diabetic. He is currently 1 packet per day smoker and on aspirin and high dose statin. Past surgical history is significant for left SFA stent.
His left SFA stent, and now his symptom on the left, the same area.
Yes.
What does he have now? What we called it?
It's critical limb ischemia.
Correct. Critical ischemia because he has a wrist pain. Okay.
Yes.
All right. So what do you do next? So in the clinic, he came to you. He has a wrist pain. He has SFA stent before. He's in aspirin already on statins. You know. So what do you do next? You're in the clinic. What do you do next?
Yeah, we started by history of the patient about.
I don't need that history because you already took a history.
Okay,
So,
more details about if there is any another risk factor, hypertensive, hyperlipidemia, similar attack, family history, history of fever. About the ambulatory and there is claudication. There is wound, if there is any wound, cardiac disease.
okay. So did all of that.
Yeah,
And
after
what else?
physical examination.
You see, the most important physical exam. So in the clinic, you may ask a couple of questions. As you say, if has any heart issues, you know. Second question, how long the stent, when was the stent put? You know, it's important for you to know is an old stent or new stent, you know, because the way he sound, he has occluded his stent, correct? Because critical limb ischemia. So it's important to know when the stent put in. Is this put in like 2 weeks ago? Is that something happened quickly, like hypercoagulable patient? was being there for 7 years, and this is normal course for the stent, you see. So this information will help me a lot in make decision. Then you go to physical exam. It's very important, physical exam, to do, you know, see the pulses, where's the pulses, you get an ideas. And then after that, what are you going to do? What kind of test you order?
I will start it by duplex arterial ultrasound and API.
ABI and duplex ultrasound, but usually we do an ABI because ABI is supposed to be done in the office, you know, in the clinic. You know, after duplex, I have to go there to the vascular lab, whereas ABI can be done at the in the clinic. You know. All right, so he has no other significant medical history, and the general physical exam is unremarkable. He has palpable right femoral pulse. He's probably on the left. Remember. Dorsibus artery and posterior tibial artery. So the right leg looks perfect on the right. The left has an absent femoral and pedal pulses with monophasic pedal signals. EBI on the right 0.9, on the left 0.4. How do you interpret this finding, and what would you do next?
I will admit the patient and keep it in the heparin infusion and more investigated him. I will do a CTA for him or angio with possible intervention.
Yeah, you see, this is, as I said, as we mentioned before with Bassam, you cannot say, I'll do CT or angio, you know? You see, it just tell me you are not confident we're going to do it, you know? So you have to decide. If you are tomorrow in the clinic, what are you going to order?
Angio. Yes, angiogram. Diagnostic
angiogram.
And angiogram.
So you're going to go right away to angiogram.
Yeah, diagnostic and proceed.
Okay. You go there from the left side, okay? You go from the right. We're going to go right or from the left side? You see now, now you see I stopped now all my questions. I went to different direction now because you direct me now to this directions. So you told me you're going to do an angiogram, okay? So how are we going to do angiogram? This is my question.
I will do it from the contralateral side.
From the right side, okay. So you go from the right side, you do an angiogram. And diagnostic angiogram, okay. And you go there and you find that there's complete occlusion of the left common and external iliac artery and common femoral artery. What do you do? It could happen, right? This is a scenario.
Yeah.
I'm just giving you a real scenario. There's no pulse on the left leg. So you say, okay, I do an angiogram, I go there. I'm not saying you're wrong. Remember, I'm not saying wrong, but I just want to know if you decide to go this way, what way, why you want, what going to good happens, you know? So you have
try to cannulate. Try to cannulate it.
Okay.
The occlusion.
Common is already occluded.
Yeah.
Common femoral occluded, common iliac is occluded, external iliac is occluded, you know? And then he only has a profundus open. And this phase occluded, popliteal below the knee is open.
Yeah, this patient for surgery is better for him. I will planning to do for him
at this level and plan him for surgery, correct?
Surgery, yes.
Okay. Let's say, are you going to do the same day or going to do it later on?
No, later on, because I will do mapping, arterial venous mapping, and prepare him for surgery.
So, okay, let's go retrospective. Let's say if I order CT angiogram, would you still take him for angiogram or take him right away to surgery? You follow me, Rafat?
Yes.
Yeah, I say if you do a CT angiogram and you see same finding, you're going to plan him for surgery, right? You're not going to take him for angiogram. There's a reason why angiogram in this scenario, I don't think is a good option. I did all this one to show you why it's not a good option. Because you may enter surprises. You see, so CT angiogram is more important here than CTs. as I mentioned before, the only time we go angiogram if you have a femoral artery pulse, but as far, because anything we can fix in the vascular, but common femoral, we cannot fix it. So we don't have a common femoral pulse. That means could be possible, either iliac occlusion or common femoral occlusion. If it's a common femoral artery occlusion, then a surgery, then I have to be prepared for that ahead of time. So if I have a common femoral pulse, I have no problem. I can go with angiogram, as you said, because I think like 99% I can fix endovascular. But there is no common femoral artery pulse, then 50-50. And I don't want to take that chance. Then I have to go with CT angiogram. Okay?
Okay.
When patient has no femoral pulse, always good CT angiogram. Don't go over angiogram. You know?
Okay.
All right. So on this patient, it's better to get a CT angiogram. Okay.
Okay.
All right. Let's see. So they did a CT. Most of them did an angiogram, CT angiogram. The cardiac vein is 3.5. Did they tell us what the angiogram? The angiogram demonstrates moderate common femoral artery and profunda femoris stenosis. Like here, they did an angiogram. You see, I don't, as I said before, I don't agree with whatever everything they say in this book, you know, because this one I will prefer not to do it. Like this one, they got lucky, they found only stenosis, but you can find an occlusion. So it's better really to get, anytime you don't have femoral pulse, always try to get an angiogram. CTA is better, okay? So this one, he has a moderate common femoral artery and profunda femoris stenosis, flush occlusion of the SFA, thrombosis stent, reconstitution of below knee popliteal artery, single vessel runoff. What would you do next?
From this finding, I will do left femoral endarterectomy with profundoplasty and bypass fem to below the knee. Yeah, below the knee. With
reconstitution of the below knee popliteal artery. There is a single artery and posterior tibial artery into the foot. Yeah, so below the knee popliteal artery is open, so it's good.
Yeah.
Okay, good options. Are you going to use the right or left vein?
An ipsilateral side, left vein.
Because a good size vein. Are you? Why
Yes.
don't do endovascular?
It is a long segment of occlusion and chronic.
It's a chronic and the long segment of occlusion. It is, and second thing, you have to fix his common femoral artery also. And the reason why surgery here is much better, you know, a long occlusion. So I agree with that. All right, let's go to next. Cardiac workup was normal, describes as surgery. So it's described as surgery. How are we going to, where's the incision you do it, all the things. You want to go through it, or Khas, you know it? We don't have to go through it.
خلاص.
Khas,
But some he said.
the only thing we ask you about how you're going to tunnel, this is that difficult. You can expose the common femoral, expose the popliteal below the knee. You have to tell them exactly how you do, what fascia you open, how you dissect the muscle down, what's the name of the muscle, expose the artery, you know. Where's the vein, media or lateral? How do you mobilize the vein to the media or laterals? This is a question, you have to know exactly how you do a surgery. And then the tunneling, you know, how you do that tunneling is different way. Whatever you want, it's just to be fine, you know. Are you going to in situ or reverse? You have to tell us what you're going to do, reverse or situ, and why. What do you prefer, in situ or reverse?
Depended on the facility.
I'm saying what when you are there, the vein is, you have a patient on the table, you have to decide, because the incision is completely different between in situ and reverse. So are you planning to do in situ, femoral popliteal below the knee bypass, or are you going to reverse the vein? I mean, you can go either way. Just have to tell me what your preference and why you prefer this way and not the other way. I'm saying there's no right or wrong answer. It's just what you prefer and why you want to this one. So I know really why you choose this approach, not the other approach.
Reverse for me is.
The reverse?
Yeah.
Okay, you can do reverse. I have no problem with that. So then you have to harvest the whole vein, and you have to reverse it, okay? The next question comes to me is that which one you do first, the proximal or distal anastomosis, and why? Well, let's go to reverse. Why you do reverse, not in situ? What the disadvantage and advantage? Each one has an advantage and disadvantage. Let's say in situ. What's the advantage of in situ?
Easy procedure, less dissection
Correct. It's
and
less
less
dissection.
complication.
Especially ischemic legs. The patient already has poor circulations. Especially when you go below the knee, you have to cut the skin, so less cutting, okay? So what the disadvantage? Otherwise, if it's all good, we should have only one option. Because we have two options, that means she has something bad about it. So what's the bad about in situ?
The fan, we cannot do the dilatation and ligated or all the branch.
No, you can do that. And after you finish, you can do an angiogram or by duplex ultrasound. You find them, you make small cut, you ligate them. It's not an issue. And if you think about the match, the in situ is better because the big vein is close to the big artery and the small end of the vein is close to the small size of the artery. So even the match is better. So everything looks good in situ. You see, less.
السلام عليكم، معليش على التأخير.
يا محمد.
أنا معليش دخلت عمليات وتوني خلص. الله يعافيك.
ما دامش عمليات خلاص الفحص يعني اعتبره منتهي. هو الفحص هو عمليات. هذا هو كله. Okay. We are talking about in situ versus reverse seventh vein. So we're looking at the advantage of in situ. It looks everything to me, it's good. It's, again, it is less cut. Match is better.
Yeah, but the valves
not
is
for
the
you,
problem.
not for you. Don't go to no.
I'm so sorry. I thought you were talking to me.
No. It's his
Okay.
case. Finished. You get your time. We don't have much time left. So Rafat, so what is the disadvantage of in situ?
Maybe we needed valvotomy.
Correct. The valvotomy is the only disadvantage. So you may damage the vein, you know.
Yes.
So or you may not have a complete destruction of the vein. So you may end with a stenosis in this area, you know, where you did not destruct the valve. So already the main issue is in situ is the valvotome, you know, which can damage the vein or you don't have a complete lysis of the valves, you know. And the second thing is that sometimes the vein is good, but like small part is bad. So in reverse, always you can cut it and put it back together. So you have a very good vein. Where in situ you have to use the vein, whatever you have. So it's the advantage. So reverse, the advantage, you don't have to use the valvotome. But what the problem with reverse? What the disadvantage?
Discrepancy, the diameter between the proximal and distal.
Correct. The discrepancy because the smaller is up and larger is down is the main issue. And I think the main issue is for me really, but even I only like reverse, I don't like in situ, but the main issue is I think you de-arterialize the vein because vasa vasorum, you know, they supply the veins. So when you dissect the vein completely out, I just feel that it loses a lot of the blood flow. Maybe it's contributed to the stenosis. I don't have anything scientific to prove that, but it's just my feeling is the only problem with that. That's why in situ you still have the vein in the same place. You have vasa vasorum intact. The circulation to the wall of the vein is better, but this is the problems. Okay, so let's go back to the most important question for me is which one you're going to do, the proximal or distal anastomosis first?
Proximal.
If you do a reverse, proximal. Why proximal first, not the distal?
Inflow. Keep it thrombosis.
I mean, you have two anastomoses. If you do this one, why does that make a difference? Why should they go the proximal first or the distal?
To assist also the bypass to kink it if there's any kinkage for the tunneling.
Correct.
Keep it the inflow inside.
Correct. So we do an inflow, so the inflow will stretch the vein and prevent kink when you tunnel it, you know. And the second thing is the vein will be stretched a lot after you do an inflow. If you do the outflow first, then you do an inflow, you're going to find the vein is too long, you know, and it can be kinked. So always start when you do a vein. I always start with the inflow, then the distal. When you do a cortex, this is just a preference. I just always start the distal, then do the proximal. But this is my preference, but somebody, they do the opposite. But in the cortex graft doesn't make a difference, but in the vein make a difference, you know. All right, let's see. You complete your bypass, there's no pulse in the foot. Oops. This completion signals is high resistive. What would you do? To finish your bypass, you put your hand on the feet, there's no pulse.
I will reassess.
What the first thing you think is going on?
Most probably is the technical due to anastomosis side.
Okay, or you may
One,
imply to the
or there is a pulse needed to me, or the vein, or there is the section in the artery.
okay. So how would you know which when and how going to approach? How would you deal? What would you do now? So what are you going to do? You're in the OR. What will you do?
Re-exploration, the anastomosis, distal
How
anastomosis side.
to the exploration? This is my question. How are you going to explore it? Because this is an exam, guys. You see my point? This is an exam. This is exactly. I'm not going to ask you what the percentage of bypass, which one is better, you know, above knee, below the knee, what the percentage, what's the patency rate. I don't, this information will not be asked in the exam, guys. So don't waste your time. I may ask you like as an extra, if you have an extra time, really. But main question is technical. As you see here, I want to know if this problem, how are you going to deal in the OR? So you are there, there's no pulse, you get to explore. Okay, tell me, how do you explore?
Maybe
You're going to open your distal anastomosis, right? This is where the issue, right?
yeah,
So,
this is the one technique.
yeah, so just open, just take it down and look inside, see what's the issue. There's an issue there. There's a problem there. You know,
We can also, I can also do angiogram for the
I did
anastomosis.
angiogram. This angiogram, there's no angiogram. Let me see, you complete bypass, there's no pulse. But you don't need an angiogram. It's very obvious. I mean, you can do that, but most probably you're not going to feel any, I mean, pulse. If you have a weak pulse, you can do angiogram. I have no issue. But if you see no flow, then what are you going to do? And how can you do an angiogram? You do through the side, you know, the side branch of the vein. You do an angiogram, and you see that's no flow at the anastomosis site. So what do you do?
Phenotomy. I will make it phenotomy on the anastomosis and repair it, the defect. If there is any
So
defect,
you can cut the vein longitudinal and extend it to the graft, to the
yes,
arm.
art,
And you open this one and you look inside.
yes.
Okay. This is correct if you have a chronic bypass, because you see bypass after like a couple months, it does not relay on suture, it relay on the tissue around it. You have fibrosis. So even if you cut a suture line, it's okay. The bypass will not come apart, right? But if you do a fresh bypass and you cut through suture line, the whole suture line will come apart. Then your whole anastomosis will come out. You see my point? So if you do venotomy and extend it to the popliteal artery, you're going to cut your suture line, then your whole suture line will be loose, be cut, you know, then you're in trouble. I mean, it's not a big issue. I mean, you can still, so you can do that. I'm not saying you cannot. You can do that. You can open and look inside and try to fix what's the issue. So after you open, what you do. But my point is that when you finish, you have to remember that suture line is loose. So you have to tie it up with whatever you want to do later on, like put a patch, whatever. Or maybe sometimes you have to redo the whole anastomosis. Take the whole anastomosis down, it's better. Or like half of it, where you have a long thread, so you can tie it with a new thread. And then you have to suture it back again, the anterior half. So usually what happened, I open like the anterior half of the anastomosis, I leave the posterior half, but I leave long thread on both sides. And then I look inside, extend my arteriotomy distal to see what the issue, and try to fix it, doing embolectomy, see if any dissections, whatever, fix it. And after I finish, most probably I have to put a patch because the vein is already short now, because this is vein already cut. And you already extend your arteriotomy, so it's not enough, then you have to put a patch. Then you have to put a patch. When you do a patch and suture it, you have to tie the patch with the thread of the bypass, because so you don't get loose. You follow me, guys? but this is the way you have to talk in the exam. You know, this is exactly what you do. So on, so on, so. Okay. Okay, Rafat?
Okay, Dr. Samer.
All right. So they did an angiogram. So the static contrast and no flow distally in the posterior tibial artery. What you do next? We said that you open it. How you address your problem? That means describe the procedure. You already described that. So you open as you said, but don't forget, after you open, you have to put a patch. Okay, Rafat? You cannot just
Okay.
close a small artery. You cannot just go and open because you extend your incision through the graft to the vein graft all the way to the popliteal artery. So after you fix the problem, you have to put a patch there. Okay. There's a good forward bleeding from the bypass, but you see distal flap in the artery just past anastomosis. Then what you do?
I will fix it, the flap.
Okay. Interrupted sutures. Okay.
Yeah.
This solves the problem. And there is a posterior tibial pulse at the ankle. Quite. How will you follow up this patient after being lost to follow up the present to the clinic? Answer the question. Okay. So how do you follow up this patient?
I will follow up in the OPD with the serial duplex, arterial duplex and API every 1 month, 3, 6, and annually if there is
Okay.
no.
So you did that. How do you enter this result? This is the patient. How do you do like? No, what's that? Follow up this patient. Okay. After being lost for follow-up, she presents to clinic 1.5 years with a wrist pain in the foot. What would you do? Oops. So she came back with a wrist pain. What do you think is going on?
Thrombosis in the graft thrombosis.
Or
outflow, maybe possible the outflow.
okay, or possible severe stenosis. We don't know, right? I mean, sometimes
Yes.
we can give you. I mean, stay optimistic. Hope issue, not. But yes, could be a graft thrombosis. You can tell from physical exam. So what you do next?
I will repeat the investigation, arterial duplex and API to confirm.
Okay, you can do arterial duplex, correct. But yeah, to look at that, okay, to see how it looks, okay. So API worsened from 0.9 after surgery to 0.5. Bypass is open, that's good. But flow, this study of 30 cm per second. High velocity distal anastomosis. What does that mean? How do you interpret this result? What does this mean?
Intimal hyperplasia.
Stenosis. You see,
Yes.
I'm saying don't give pathology. Don't give them, because anything could be. We don't know. So that means you have a stenosis. That's simple. Again, exam, go back to the question, and one word, you're done. You know.
Okay.
How would you interpret this result? This means she has a severe stenosis and anastomosis. Stop. If you ask you what do you think happened, say yeah, it could be intimal hyperplasia. You know, but she has a stenosis. That means. So, what do you do next?
For angioplasty.
Okay, you do angiogram and angioplasty.
Plasty.
Okay, he may ask you how you do it. It's simple. You just go from ipsilateral, you go through it, you do balloon. What kind of balloon you use usually?
I can
Regular
use that.
balloon? Well, different balloon. Well,
Here in this area, we can use it, a drug-coated balloon.
okay, you can use drug-coated balloon, but in general, when he asks you this question, most of it he wants you to say most of it I'll use a cutting balloon because it's fibrosis, right? Intimal hyperplasia. You know, so
Yes.
usually balloon they don't respond very well to balloon. So most of the time you need to use a cutting balloon, you know, when you have intimal hyperplasia. When you have stenosis in the middle of the vein, it's different because this is fibrosis. You either respond very well to ballooning alone. But at the anastomosis, most of the intimal hyperplasia, which is usually you need most of the cutting balloon. Okay. You are able to successfully angioplasty distal lesion with return of pulse and posterior. Would you add any additional medications?
Yes, I will keep it the patient on the antiplatelet, dual antiplatelet for 3 months, then single antiplatelet for long life.
Okay, but I presume she was on anti. I mean, if she was on single, I put her on dual.
Yes.
she was on dual antiplatelets. You know, I mean, you can argue both way, but I may put her on DOAC or, you know, plus antiplatelets. But this is controversial. Whatever answer you're going to answer, I think be correct. But the only thing they want you to be sure you're aggressive with anticoagulant.
Okay.
All right, this is very good. I don't think we have a time because I have a dinner. Let me just give me 2 minutes. Let me check, guys. Let me check with the big boss. Be like 1 second. All right. Yeah, I think we have to finish. But I'm free, guys. Saturday, Sunday, even tomorrow if you want. I'm free tomorrow.
Saturday is the PAVSS, Dr. Samer.
What is that?
24th Saturday.
So what we have Saturday 24? What is that?
The Pan Arab meeting, the journal club.
Oh, you're right. You have a journal club. You're right. We can meet before if you want, or tomorrow. But tomorrow is my birthday, guys, so it has to be like, you know, after.
Happy birthday كل سنة وأنت طيب.
Nobody mentions the age, please.
Happy birthday, Doctor. Can we do it Saturday 5 p.m., Doctor?
Yeah,
سيد
I think
الشباب والله.
fine. 7 p.m. because the journal club 7, right, Ahmed?
Okay,
Yeah,
we do it at 5.
5 because we need 2 hours. So 1 hour is not enough. We need
Yeah.
2 hours.
Yeah, 2 hours at 5.
Okay, and then we still have to do one more session for AV Access, I think.
Yeah.
We'll do it
Then Sunday.
We'll do it Sunday.
Yeah.
If you want to leave Sunday for a question, last minute question, guys, you come to your mind.
Yes.
Up to you.
Yes.
طيب خلاص معناتها
Okay.
we'll do
الله
the-
يعطيك العافية وكل سنة
الله
وانت
يعافيك.
طيب.
No problem,
كل عام
guys.
وأنت بخير يا دكتور.
شكرا
العمر
شكرا
كله إن شاء الله بالصحة والعافية
بالعافية.
دكتور سامر.
شكرا. So 5 p.m. Saturday.
Yes, please.
إن
Okay.
شاء الله وأنت طيب.
Tomorrow, you want tomorrow? I have no problem if you want tomorrow. Really, afternoon, I have no issues. So we want tomorrow lessons. ولا بتحبوا خلاص Saturday is okay.
الشباب اللي يبغون tomorrow نسويها مثلا متى يناسبك؟ الظهر بعد صلاة الجمعة؟
بعد الصلاة بيكون شو الساعة 1 2 هيك شيء.
خلاص مناسب معي بعد قبل الدوام.
كويس. أنا مناسب لي.
كويس نخلص هذا السيشن وما خلصنا السيشن هذا لسه.
ايوه تمام. بكره كمان بعد الصلاه
2 p.m. متأكد ما عندي شيء بكره. What do we have tomorrow?
الصلاة عندكم يا محمد ولا عندنا؟
كويس؟
بعد الصلاه عندكم.
الساعة 1.
ايوه 1.
خلص 1 بكره سعودي تايم. اوكي جايز؟
اوكي.
خلص بكره الساعة 1 ان شاء الله.
انت طيب. ان شاء الله. مع السلامة.